I want to thank Brian and the team from Henry Ford for bringing us all together, and I want to thank our hosts in Liverpool. This has been great. I've never been here. It's sort of a mythical thing if you grew up in my generation. I want to start with a few disclaimers. I work for the National Institute of Mental Health in the United States, which is specifically committed to advancing both the science and the practice of suicide prevention. Still, my comments here do not necessarily reflect the views of my employer. I'm obligated to say that. Second, while the work of suicide prevention is not limited to healthcare, my own focus and experience has particularly been on healthcare, and my work on suicide prevention has almost entirely been in the United States. Context and details matter in this work. As our colleagues yesterday reminded us, all healthcare is local, so I need to offer my expertise is particularly centered on the United States. Third, this panel is a blind date. We did try to meet in advance to coordinate, but we were defeated by time zones and competing demands. So I apologize for my part in that, and I hope we end up more complementary than redundant. Happily, actually, I think we will, because I'm actually gonna not talk very much about money. Let's see. Nothing I'm gonna present is visual. So with apologies to those of you who think of yourself as visual learners, I'm not gonna speak without slides. And finally, and maybe getting to the point, our charge here is to talk about the economics of zero suicide. As it happens, our Suicide Prevention Resource Center in the US has a new research brief on the economic cost of suicide and self-harm in the US, which starts with a trigger warning that, quote, "This content may be troubling for some readers." Turns out what they're warning about is not the content of suicide, it's the content of economics. So, fair warning. There exists data. That report David just laid out for the UK. There are data on the economic cost of suicide, but let us also stipulate suicide behaviors are costly. They're costly in financial terms, they're costly in human terms. David addressed this. In the interest of complementarity, I will not I'll let what he provided stand. And as David also addressed, high gross costs do not themselves tell us what exactly to do, or even if there is anything specific to do. For that, we need to have specific interventions that are plausibly effective and relatively cost-effective. And this gets us to zero suicide, not as a general organizing framework, but as an inventory of specific evidence-based interventions. It's not that long ago when we had relatively little science in hand on effective interventions to prevent, identify, and treat suicide risk via healthcare. Now we do. So some examples which also came up yesterday, there's good evidence, and David addressed also, there's good evidence for the safety planning intervention, for written and telephone follow-up contacts interventions, and for certain types of psychotherapy, that these interventions substantially reduce suicide attempts and deaths, especially among people who are identified with suicide risk in emergency care. And there's also evidence that these interventions are high value, relatively cost effective in the case of safety planning, telephone post-discharge follow-up contacts, and suicide-focused psychotherapies, and actually cost saving in the case of written post-discharge follow-up contacts. So we do have effective and cost-effective tools in the toolbox. And if these tools were technology, capital T, like drugs or devices, then the patent owners of that technology would take care of pushing those things out in the world. But they're not. They're care delivery interventions, which means we need to get human beings and organizations to deliver care differently. And that's much harder than, say, getting clinicians to prescribe new drug X in place of old drug Y. So, what can we do? I will, in the remainder of my time, offer a kind of a general framework. And first, I will start with money, which is what people expect economists to talk about. People and organizations generally won't do something if it's economically unviable. We should not wag our fingers at professionals and expect them to do things that they can't afford to do. And we know that some key interventions, for example, safety planning and post-discharge telephone follow-up contacts, are generally not economically viable in community practice, especially not in general medical settings, emergency and primary care, where they may be most essential. I can spell out the challenges for these things in the US, and I don't know how or whether this is a problem in other settings, but I'm willing to bet that there are many settings where we want and even expect healthcare to furnish these services, but where we do not provide adequate resources to support that work. So we need to fix that. For that matter, if we want clinicians to screen more people for suicide risk, we get to talk about that more tomorrow, we do generally want more to screen more people for suicide risk, especially in emergency and primary care. The underlying idea is we can't help them if we can't find them. Of course, also finding them is not enough. In any case, people, providers, care systems won't actually undertake this work unless they have confidence that the patients they find can get indicated services, ideally something other than forcing them into the hospital, which is costly and also potentially harmful. But currently, providers and care systems don't have such confidence because the indicated services aren't generally available because we don't fund them properly. So, these are interconnected things. Also, when we do take steps to fund a new service, we typically focus on covering the cost in equilibrium, i.e. the cost of delivery when something is standard care. But there are typically big costs of moving the world from we don't do this to we do this. And in most places, certainly in the United States, our healthcare financing mechanisms don't really provide for supporting that transition. The underlying investment, the new staff, the training, the technical assistance. We don't have models for funding that stuff. We just expect we've turned on new billing mechanisms, imagining that people make it to the point of we do this and furnish the service, and they just never make it there. But it's also not only about money. Another issue is knowledge. People and organizations won't do things they don't understand. Probably the most effective time to teach people is in their initial training, but current suicide prevention content in most types of technical training is very weak, even for behavioral health providers, as Julie Goldstein-Grummet reported referenced yesterday, but especially for general medical providers, GPs, pediatricians, geriatricians, emergency clinicians. They just don't get this stuff in their initial training. Yes, as we heard yesterday, more than 70% of suicide decedents present to primary care in the months before they die, but those clinicians in practice have little or no training in identification or treatment of suicide risk. So we should fix that. Again, I think with a big focus on initial training, because training existing practitioners to do things differently is crazy hard. A third area of focus should be logistics. To borrow from my colleague Greg Simon, who many of you know, we want to make it easier for clinicians to do the right thing and hard to do the wrong thing. This is a central purpose of health IT, whether health IT means fancy computer systems or health IT means spreadsheets or checklists that are printed out on paper. But current health IT tools related to suicide prevention are generally poor, and there's no evidence that market forces will be enough to fix this. For example, we now have multiple valid instruments for suicide risk screening. Yay! But as we heard yesterday, just having the tools is not enough. Clinicians need to be willing to use them and able to use them effectively. So we need best practices for that, and we need to push those best practices out in the world so that they're available. Just pointing people to the instrument and assuming that they'll figure out how to use the instrument in some valid way is wrong. It won't work. Finally, for now, there's accountability. We improve what we measure, and what we're typically measuring is not enough. we need information on patterns and correlates of suicide risk. Most immediately, this means we need better data, not just on the people who attempt or die by suicide. We also need data on the people at risk for those outcomes who end up not having them, the denominator. As a practical matter, this means we need to link healthcare and health insurance cohorts to mortality records. In the US, we do this routinely for cancer and for heart surgery, but with some important exceptions, including health systems that are represented here. We do not do this for suicide risk. We don't do it for overdose risk or for mental health problems or for substance use problems. We just don't. For those of you in countries with national health systems, please push, if you're not already doing it, for routine tracking and public reporting of survival after key healthcare events. For example, after an emergency department visit for suicidal ideation or intentional self-harm, or after discharge from psychiatric hospitalization. It's not enough that the patient leave the hospital alive. The outcome we want is that they're still alive 3 months and 6 months and 12 months later and so on. And that means we have to follow them downstream from healthcare and track and report those things and create a framework of accountability and expectation that it is a responsibility of healthcare to attend to that somewhat longer horizon for the people in front of them. We also need to make sure that emergency departments and hospitals document how an injury occurred. ICD-9, ICD-10, and I think also ICD-11, which maybe the US will adopt in my lifetime, but I'm not optimistic about it. We just got to ICD-10, as Brian pointed out yesterday. All of those systems, I think, require using 2 separate diagnosis codes to document how the injury occurred. One for the physical thing that happened to you, the laceration of the wrist or the burn or the gunshot wound or whatever, and a second code separately for whether that was intentionally self-inflicted or unintentional or the result of assault. And that second code very commonly does not get documented, at least in the US. I don't know what the practice is in other places, but I guess I wouldn't assume necessarily that everybody else is doing it right. Some of us in this room just had a new paper accepted for publication documenting these gaps in the US. We can't provide good clinical care if we don't document how the injury occurred. We can stitch the person's wrist up, but we can't determine safe disposition. We also can't do quality assurance on injury prevention if we can't distinguish intentionally self-inflicted from unintentional, from assault injuries. Finally, we need information on current service provision of people with relevant characteristics and experiences. Who gets indicated suicide prevention interventions? Who gets screened and assessed? Who gets safety planning and follow-up contact? For now, I'm not even asking who gets those things with adequate fidelity. Who gets them at all? We heard from colleagues yesterday that even in relatively sophisticated health systems that are committed to implementing zero suicide, it's crazy hard to document which patients actually got which services. We need to fix these things too. I will close there and just come back to the idea of complementarity. So I agreed with everything that David said. I actually don't have all the technical knowledge about the things that he was presenting, but I could have followed a similar framework. What I guess I would argue is that some of these additional things that I was offering might not be what you think of as economics, but they are what an economist, anyway, this economist thinks of as part of the incentive environment that affect whether we actually implement any of these services. So let me close there. Thank you.